All right, so the next is our systemic problems or things that can cause failures, that can cause fatigue. So chronic renal failure, chronic kidney disease is one of them. People can come in with fatigue and they may not have too much else going on. And then these are the patients. So what kind of population are you going to think that might have chronic kidney disease that's causing fatigue? So people with uncontrolled hypertension and uncontrolled diabetes, they are going to develop kidney disease. That is just a very, very unfortunate consequence. So you will think about this in this population. So their symptoms and signs, they're going to have swelling, shortness of breath, polyuria, and initially they have hypertension, but then when the kidney failure is advanced, then they can develop hypertension. So just keep that in mind. So you can see, in addition to fatigue, if they have swelling and they have shortness of breath, maybe because of fluid retention and maybe polyuria, then you will of course suspect this as a diagnosis. Additional symptoms of signs of kidney disease would be because of multiple problems that are happening because of dysfunction in the kidney. So you can see the kidneys produce erythropoietin. So when that's not enough, it will cause anemia of chronic disease and people will have anemia. So their erythropoietin levels will be low. Then kidney disease can also cause uremia. So there is too high creatinine and BUN. So when blood urea nitrogen is too high, that is a condition that's called uremia. And when people have uremia, they can get, you can see, uremic gastritis, uremic pericarditis, and uremic encephalopathy. So all these itis and encephalopathies, these will result in symptoms. For example, uremic gastritis causes nausea and vomiting, pericarditis will cause shortness of breath, pleuritic chest pain, encephalopathy will cause dizziness and confusion. So you're all familiar with it already, but these are the main uremia symptoms, and there can be others too. And then people can get metabolic abnormalities, so they can get hyperkalemia because of kidneys are not working, which can result in arrhythmias and palpitations. Hyperkalemia typically causes tall T waves. So tall T waves, which in somebody who has fatigue and swelling, definitely look for potassium levels and kidney function. So that is something to keep in mind. Hypocalcemia also occurs because of renal failure, and we already went through it. So this will result in secondary hyperparathyroidism, and of course then they develop bone pain and fractures and renal osteodystrophy, and then finally, if things go too bad, they can get metabolic acidosis and shortness of breath and coma. So metabolic acidosis is going to be basically the final thing that will lead to loss of consciousness. So therefore we need to be cognizant of this diagnosis. The labs to draw, if you're suspecting it, of course you'll draw all kinds of labs, but the basic ones just to check for kidney function is going to be your BUN, creatinine, metabolic panel, and CBC, and then of course you can draw all the specific labs for the kidney disorder itself. The treatment is treat the underlying cause, like such as hypertension and diabetes and other things. But if creatinine is too high, where the, specific indications have developed, then people will need dialysis, and usually dialysis is for life. The indications for dialysis are so there are basically many indications, but the main ones that have been published in literature are metabolic acidosis, hyperkalemia, and uremia. Metabolic acidosis, high potassium levels, and uremia. So by uremia, I mean all the uremia complications, all these three things, or anything that is resulting from uremia. So, if there is too much fluid overload. But these three are the main ones that have been published. So it's not necessarily a single creatinine level. So it's not like if somebody's creatinine is 3 or 4, then you definitely do dialysis. It's all based upon the clinical complications. Here is a slide showing the EKG. So you can see really tall T waves. So this patient doesn't necessarily have any cardiac injury or ischemia, which is one of the things that can cause tall T waves, but this patient has hyperkalemia. So that's one thing that you can see. And then heart failure patients, and we already reviewed heart failure in dyspnea and I think couple of other things. So but they can also present with fatigue. So they may not have any symptoms of heart failure as such in the beginning, especially people who have a diastolic dysfunction. They may not have too many symptoms. All they have is fatigue. So what kind of patient population you're going to think about has heart failure, these are going to be the people who have risk factors. So they may either have a previous ischemic heart disease, diabetes, hypertension, smoking, COPD, or family history, or things like that, right? So all of these things are going to place anybody at risk for heart failure. And then there are many other things that we reviewed in the I think dyspnea and chest pain topics. But anyway, just keep all those in mind. So whenever you suspect somebody has a risk factor for heart failure, then you're going to think about this. So in addition to fatigue, these people can have symptoms. The classic symptoms, again, you already know, is dyspnea, orthopnea, and PND for the left-sided dysfunction, lower extremity swelling, abdominal swelling, jugular venous distension for the right-sided, and then on exam they may have S3 gallop, they may have crackles, they may have pitting edema, of course elevated JVD, they may have or pressure, they may have ascites and hepatosplenomegaly. So it's a very classic set of symptoms and signs that people can have, but again, all of these are going to not necessarily develop early on in the disease. One of the earlier symptoms may just be fatigue, or maybe some exertional dyspnea, or just regular dyspnea, and then of course orthopnea. So the labs to do would be BNP, again, is one marker. It's a blood test, or it's a very convenient test. It's a very good test, I think, because it can rule out heart failure if it's normal, if it's really low, and if it's high, then of course you can take clinical context into account too. But in addition to that, you can do chest x-ray. It will sometimes show pulmonary edema because of too much pulmonary congestion, and then echocardiogram, of course, will give you the definite picture of the ejection fraction. But because this test takes some time to draw, it may take a few days. Sometimes you might want to go ahead and draw BNP right away if you need to, and that will give you an idea. Treatment, of course, you will avoid further injury. You will control the blood pressure, diabetes, all these things you will avoid or control. And then the medication treatment is everybody, I think, who has heart failure needs to be on statins, blood pressure lowering medicines. So ACE inhibitors are great. Then you can use cardioselective beta blockers. If the patient has any symptoms of congestion or fluid overload, such as edema, you will use diuretics. Aspirin will need to be given judiciously based upon the clinical picture and other risk factors. Then if the patient's heart failure has advanced and ejection fraction is really low, then we can use inotropic agents. Finally, the defibrillators with a really low ejection fraction, and then heart transplants can also be done. Another thing that we need to talk about is that beta blockers, although are great for cardiac for cardiac remodeling or myocardial remodeling, so they're great drugs for heart failure, but they can also cause fatigue because they are blockers. They block the beta receptor, so they will cause fatigue in themselves. So this is really sort of a catch-20 situation where you want to give the beta blockers to the patient who has fatigue, but then also they themselves will cause fatigue in some patients. So this is an unfortunate vicious cycle of congestive heart failure. So you can see that people have left ventricular dysfunction or right-sided, and then causing low cardiac output, and then causes low pressure and low renal perfusion. So kidneys are going to release a whole lot of different biochemicals and hormones, which will result in further dysfunction, and then fatigue will worsen and worsen. All right, so the next is the liver disease. So we'll talk about liver disease here quickly. Fatigue is one clinical symptom that people can present with when they have liver disease, very common. And then the main causes of liver disease are going to be your alcohol and viral hepatitis. Those are the most common causes of liver failure or cirrhosis in the US. But then, or in this, you have hepatitis C basically, and then alcohol. And then you have non-alcoholic fatty liver disease. It's also becoming more and more common, but usually these people don't develop cirrhosis. You have drug-induced liver injury or DILI. Then you have autoimmune hepatitis and primary biliary cholangitis. So in addition to fatigue, they can have again the symptoms of fluid overload, lower extremity swelling, abdominal swelling, and shortness of breath. And in addition to that, they have some special features going on here. You can see that these people, when they develop cirrhosis, basically that is fibrosis of the liver. So that is a pathologic diagnosis. It's not necessarily a diagnosis based upon one symptom or one clinical sign. and this is just a pathologic diagnosis. That this basically means liver has become fibrotic. When fibrosis is going to happen, it's going to cause portal hypertension, and that will cause varices. So when people have varices, they have upper and lower GI bleeding, and then it can also precipitate portal hypertension can also precipitate ascites. So whenever the liver is not working, in addition to portal hypertension, there is going to be liver function catastrophe. So there is going to be multiple things that are going to happen. Liver is not going to make protein. It will cause edema, lower extremity edema, because remember, one of the causes of lower extremity edema is low protein levels. So lower extremity swelling or edema in the case of liver disease is going to be because of two reasons. One is hypoproteinemia, and the other one is portal hypertension, right? So just remember that these two findings, portal hypertension and hypoproteinemia, will cause lower extremity edema. So there are two mechanisms happening. And then clotting factor deficiency can cause INR levels to rise, and then it can cause bleeding. Thrombocytopenia will cause bleeding. People can get some of the smaller features of cirrhosis, so these are not going to be very common early on, at least. So people can get gynecomastia, spider angioma, Caput-Maggiosi, and jaundice. So these things are going to be late, and also these are not going to be always present. So remember, the main things are going to be your edema, ascites, varices, GI bleed, bleed because of the clotting factor, and then thrombocytopenia. These are the main ones. And then finally, when people bleed, of course, what happens, they get into hypovolemic shock, and then they can also go into coma, unfortunately. So labs to draw would be liver function test. Of course, to look for hepatorenal syndrome, you will look for creatinine, BUN, and metabolic panel. And then treatment, you treat with diuretics. So fluid overload condition will need to be treated with diuretics. We'll have to control the portal pressure by giving some beta blockers, so usually very low dose. Avoid any further injury. That is the main thing. So these patients should absolutely not drink alcohol. They should not take any drugs that can cause further liver injury, for example, your benzodiazepines, your statins, some of the antibiotics. And then these people can be placed on list for liver transplant, but of course, they don't always necessarily get it. This is done based upon a MELD score or child score. In the US, MELD score is more commonly used, which I think at this point you don't need to really know too much about it, but basically that's calculated based upon bilirubin, INR, and creatinine. So here are some of the features: spider angioma, then you have your Caput-Maggiosi, which is dilated capillaries, and then you have jaundice.